Okay, good morning, everyone. I would like to, where I come from, my hospital, St. John in Porto. I'd like to thank the organization and to the Portuguese Neonatology Society for inviting me to be here presenting and talking to you. Thank you. And this is where I come from. This is St. John in Porto in the north of Portugal. It's very similar to Santa Maria here in Lisbon. And my talk today is about corticosteroids on bronchopulmonary dysplasia. So let's remember a little bit what it's about bronchopulmonary dysplasia. Bronchopulmonary dysplasia remains today and is still, and it will remain a major morbidity in very preterm babies. And it affects about 50% of infants delivered below 29 weeks of gestation. So lung inflammation is the main pathological feature, and this is why corticosteroids have been tried and have been studied a lot over the last 30, 40 years to reduce bronchopulmonary dysplasia. Now we have the slide. How do you feel about corticosteroids for preventing bronchopulmonary dysplasia? Do you use it or do you don't use it at your unit? So the question is for preventing, okay, okay, I think we have, we don't need more answers. I see one, to get patient off the ventilator, okay. Why don't you use inhalers? Okay. We use it. There is someone that uses cortisol, necessary Evial. I like that necessary Evial, and I like that to extubate patients from the ventilator and selective use, yes. There are people still voting. There are two participants. Love and hate. It's a collaborative decision. Hydrocortisone versus dexamethasone, sometimes when are the only option. Some people very, okay, I think you all finished. Okay, there is no, we don't have any position. I even don't know what to say. In my unit, we don't use to prevent. So to prevent bronchopulmonary dysplasia, we don't use it. So what measures do we know today that can reduce bronchopulmonary dysplasia? We know that avoiding invasive mechanical ventilation, using minimally invasive surfactant administration, ventilation with target volume, start caffeine very early, use of vitamin A and involving parents and or using a NIT cap can reduce BPD. We know that. It's proven today with meta-analysis, many studies. So many authorities have a role for corticosteroids. So the European standards of care, for example, they recommend to use corticosteroids and as systemic corticosteroids after the first week of life to extubate ventilator-dependent infants. So this is probably the position of most of the authorities on corticoids today. And this is what I am going to talk about today. So my questions now at this moment are, why systemic route and not inhaled route? Why only after the first week of life and not before? And why only to ventilator-dependent infants and not to all preterms? So these are my questions that I am going to discuss. And now the slide asks, do you use corticosteroids for the prevention of bronchopulmonary dysplasia? Yes, inhaled route, yes, systemic route, yes, systemic and inhaled, yes, intratracheal. Combined with surfactant, yes, we use all of the above. So. 68% yes, systemic route. Okay, I think 71% use the systemic route. Shall I proceed? I think let's proceed. So 72% use systemic route. We don't use corticosteroids, systemic and inhaled route 5%. Yes, we use all the above. Yes, intratracheal combined with surfactant. I can see how much percent. But majority use systemic route for prevention. Oh, I didn't know that. Okay, let's go on. Do you use corticosteroids for the treatment of bronchopulmonary dysplasia? Not preventing, but for treatment? Okay, yes, systemic, 64%. Okay, the majority uses systemic for treatment. Let's go on. Well, what happened? So my questions were to why to use after the first week, why use by systemic route, and why to use ventilator dependent. And my answer is easy, because there are benefits and there are risks. It is not possible to use corticosteroids in very preterm infants without risks. So whenever you use it, you are going to have risks. So the trick is to balance between the benefits you want and the risks you don't want. So this is the difficulty in using corticosteroids. How much shall I use and how much I shall don't use? Because you are going to have risks. So that's why you want the benefits, but you don't want risks. Okay, let's start with early systemic corticosteroids. Early systemic are those studies that included corticosteroids during the first week of life. So I believe that some units of you use systemic during the first week of life. There are 32 trials over these last years, 20, 30 years, 32 trials. Of them, 21 with dexamethasone, so the majority of trials were with dexamethasone, and 11 with hydrocortisone, and they were compared with placebo or nothing. These trials included over 4,300 infants, preterm infants. In these trials, gestational age and birth weight varied considerably among the studies, and regimens of corticosteroids also varied among the studies. So early systemics reduced the rate of bronchopulmonary dysplasia at 36 weeks, and the combined outcome mortality, or BPD, at 36 weeks. Most of the reduction on bronchopulmonary dysplasia emerged from trials and studies with dexamethasone and not with hydrocortisone. So hydrocortisone does not seem to be very good to reduce bronchopulmonary dysplasia. Hydrocortisone reduced mortality at the latest reported age in these studies. So hydrocortisone reduces mortality or later mortality, and dexamethasone reduces more bronchopulmonary dysplasia. They act differently. But when we join together, dexa and hydro, the outcome is reduced. So early systemic dexamethasone reduced the risk of death or BPD and BPD among survivors. So dexamethasone only was effective to treat bronchopulmonary dysplasia or to prevent. But there are risks, and early systemic corticosteroids increased the rates of cerebral palsy in later childhood. And most of this cerebral palsy occurred with dexamethasone, but not with hydrocortisone. So early dexamethasone increased the rate of combined outcome, cerebral palsy or mortality, but hydrocortisone did not. So dexamethasone seems very good to reduce bronchopulmonary dysplasia, but causes cerebral palsy. There is one trial of early prophylactic hydrocortisone. This was published by Olivier Baud in Lancet in 2016, and they included over 500 patients treated during the first 10 days of life with a low dose of hydrocortisone. So this study showed that hydrocortisone increased survival without bronchopulmonary dysplasia at 36 weeks. I think this is the first, and this is the only one study we have with hydrocortisone during the first week of life that gave good results, but it was a very low dose, so it gave good results. And I am not sure if we are not going to use this in the future. But by now, it is the first study, and we need to prove it. So we need more studies like this to prove that this is really true, and we can use it in our routine practice. In this study of Olivier Baud, the rates of cerebral palsy at 22 months corrected age were similar to control, to placebo, and 5-year cognitive outcomes were good. So hydrocortisone seems to be good at these doses, use it during the first 10 days of life. But as I told you, this is the first and the only one study you have with this dose. We have to replicate this study to see if we can use this in the future. So it's not recommended by now, although some units I think they use it. Other benefits from early systemic corticoids are lower rates of extubation failure, of PDA, and severe retinopathy of prematurity. And some adverse effects are gastrointestinal bleeding, intestinal perforation, hyperglycemia, systemic arterial hypertension, hypertrophic cardiomyopathy, and Graves' failure. Most of the benefits and most of the risks occur with dexamethasone, except for gastrointestinal perforation that occurs with both dexamethasone and hydrocortisone. These effects are reversible when you stop corticosteroids. So these early systemic corticosteroid studies have limitations. Most of the studies focus only on short-term outcomes, not on late-term outcomes. So they focus on ventilation and on oxygen dependence until discharge, and they didn't assess the patients at 2 years or 5 years old. Again, also these studies were not powered to assess neurological outcomes. So data on true long-term benefits versus risks cannot be fully determined with these studies. They were not powered, and they didn't assess the neurodevelopment outcomes. So as I told you, the Premiloc trial is the one that needs confirmation and is the only one that we probably can use in the future. Hydrocortisone in low dose. So what about late systemic steroids? In 2021, Lex Doyle performed a systematic review And she found 23 trials, and we have at least one more now that I'm going to talk later. So now we have 24, but in 21 we had 23 trials. Again, dexamethasone with 21 trials, much more study than hydro. These studies included over 1,800 patients. Most of these babies were intubated and ventilator dependent when they started the corticosteroids. The duration and the cumulative doses of steroids varied significantly among the studies. These studies of late systemic steroids show that they reduced rates of BPD mortality and combined outcome BPD mortality. The effects of this reduction came from studies with dexamethasone rather than hydrocortisone, but we can see that hydrocortisone, there were only 2 studies. And what about cerebral palsy? Did the late systemic steroids cause cerebral palsy? Okay, looking at these studies, there is little evidence of association of cerebral palsy. Rates of cerebral palsy were similar to controls. And most of the studies were not powered to detect important neurodevelopmental harm. So again, they were not powered, so we don't have a conclusion. I can say they are associated or not. So there is a trial, a recent trial that was published in 22 in New England by Christy Waterberg. This is an American study, an American trial, with hydrocortisone in a low dose for intubated and ventilated patients after 7 days of life. And again, hydrocortisone did not significantly improve survival without bronchopulmonary dysplasia nor reduced cerebral palsy. So hydrocortisone, use it after the 7 days of age can only extubate patients, but do not reduce bronchopulmonary dysplasia. So most of the effect on bronchopulmonary dysplasia comes from studies with dexamethasone. The group of Netherlands of Anton van Kam, they have performed the STOP BPD study, and they assessed some of the patients' neurological. This study used hydrocortisone after 7 days of life to reduce bronchopulmonary dysplasia, and they assessed the brains of the preterms, of 59 preterm babies, and they concluded, they verified that the brains, the volumes and the areas of the brain were the same as the controls. So they conclude that systemic hydrocortisone was not found to be associated with a significant difference in brain development compared to placebo. So the effects of cerebral palsy and neurological development abnormalities seem to be related with dexamethasone only and not to hydrocortisone. There is another study, this is the follow-up of the STOP bronchopulmonary dysplasia study, where the patients were analyzed at 2 years of corrected age, and the authors found no difference between hydro and placebo. So neurological harm seems to not be present with hydrocortisone. Other benefits from late systemic corticosteroids were lower rates of extubation failure, fewer infants being discharged home on oxygen, and adverse effects were hyperglycemia, glycosuria, systemic arterial hypertension, cardiomyopathy, and severe retinopathy of prematurity. So my question now is, when do the benefits of late systemic corticosteroids outweigh the risks? So we have to balance between risks and benefits. The current recommendations allow to consider low-dose corticosteroids in ventilator-dependent preterm infants. There are 2 studies, one from Lex Doyle from Australia and one from National Institute of Child Health. In both studies, they were methodologically different, but they had the same objective. And the objective was to assess if the patients in the low risk of bronchopulmonary dysplasia have any benefit when they do corticosteroids. So they compared the effects of corticosteroids when the patients are in the high risk group or the low risk group. Although differences in methodology in these studies, they agree that corticosteroids should be reserved for infants at high risk of bronchopulmonary dysplasia. If you give corticosteroids for patients at high risk, they are going to have benefit. But if you give corticosteroids for infants at lower risk, they are going to have harm and no benefits. So corticosteroids should be reserved for infants at high risk of bronchopulmonary dysplasia that in the clinical practice are the ventilator-dependent infants. Which drug, which dose, which duration of treatment should I use in my patients if I want to use corticosteroids? So all of the authorities agree that dose and duration should be minimized to reduce your risks. There are two trials, one with low-dose hydrocortisone and one from National Institute of Child and one with low-dose dexamethasone from Australia, from Lexdoyle, from Australia. So this 10-day treatment of low-dose hydro or dexamethasone have been shown, they do not reduce bronchopulmonary dysplasia, but they facilitate extubation. So the dose of dexamethasone to reduce bronchopulmonary dysplasia should be over 2 milligrams per kilo, and DART uses 0.89 milligrams, so less than 1 milligram per kilo. So doses over these, there are no studies with later outcomes. So it's a risk to use doses over this. And they are not recommended because we don't have the outcomes. We don't know if they can cause cerebral palsy. But both of these doses, regimens, can be used to extubate ventilator-dependent infants. Again, dexamethasone seems to be much more effective than hydrocortisone to extubate patients because with low-dose dexa, you have to treat 2 to extubate 1. And with hydrocortisone, you have to treat 9 to extubate 1. So, but you can use one or the other or another. So I saw that some of the units use inhaled corticosteroids. So let's change from the systemic route to the inhaled route. Now, early inhaled steroids, we consider early when they are started in the first 2 weeks of life. So there are some studies. They lower, so early inhaled steroids, mostly budesonide. There are some studies with others, but mostly budesonide. Lower the rates of bronchopulmonary dysplasia and combined outcome mortality, or BPD. Other outcomes were not good. Mortality before follow-up is increased, and combined mortality and cerebral palsy is increased. So early inhaled steroids seem to be good to reduce bronchopulmonary dysplasia, but they are associated with increased later mortality and cerebral palsy also. So they should not be used. And the most important and which has the majority of the patients of these studies, it was Neurosis trial. Neurosis trial showed that budesonide by inhaled route during the first 14 days of life reduced bronchopulmonary dysplasia, but increases mortality. So this Neurosis trial influences all the analyses with other trials. When you join other trials with this one is the most powerful, influences the other. So the effects of these trials emerge and mortality is increased. Later mortality is increased. So they are not recommended because of this. Otherwise, it would be wonderful. But so what about late inhaled steroids? There is a review from the Cochrane published in 2022 of late inhaled steroids. This review was also performed by the Anton van Kamp group in Netherlands. It included 7 trials involving about 218 preterm infants. It's not a big number of patients. And the evidence was very uncertain regarding outcomes. namely mortality or bronchopulmonary dysplasia. And there was a paucity of data on short-term and long-term adverse effects. So it is not known if inhaled steroids after 7 days of life reduce mortality or bronchopulmonary dysplasia. There is a need for larger studies. So we don't know the benefit or the risks of late inhaled steroids. We don't know. We don't have a number to say that we can use it or not. Comparing inhaled with systemic to see which route can be the best one. There are 2 studies, 2 trials, 2 reviews from the Cochrane. Both of these reviews were characterized by a small number of studies and participants, complex study designs, and limited long-term data. Early inhaled versus systemics, no difference for BPD, mortality, or CP. And late inhaled versus systemics, no evidence for any benefit or harm because we don't have data. So inhaled are not superior until today. With studies we can say that inhaled are superior to systemic. So systemic seem to be superior to inhaled. I saw also that some of units, or I didn't see the number because it was so down that I couldn't see, use surfactant with corticosteroids or budesonide with surfactant. So it can be used. There are some trials. There are at least today by now 12 trials, including over 1,300 patients, and they have shown to reduce the risk of bronchopulmonary dysplasia, death or BPD, and also mortality. They seem very promising. There are 2 trials going on. This trial is still going on with budesonide, and this is from Australia and New Zealand. This is going on, and this is from USA, from National Institute of Child. So we are waiting for the results of these studies. The results of these studies should be the short term, but we also need the long-term outcomes like cerebral palsy at 2 years. So they will probably take some time to have results. But surfactant seems with the corticosteroid seems very promising, and I believe we can use it in the future if the long-term outcomes are good. So let's summarize what I have been saying, and let's see the clinical implications. Going back to early systemic steroids. So we saw that dexamethasone should not be used early because it causes cerebral palsy, okay? More studies with prophylactic hydro are needed during the first week of life because we only have 1 study and we have to replicate. So hydro, maybe or not. Dexa, no. What about late systemic? Late systemic steroids, they have a role for infants who cannot be weaned from invasive mechanical ventilation. Dexa, as I told, in a cumulative dose over 2 milligrams per kilo, reduced BPD, but the safety at 2 years old is not established, and it's not recommended. The role of systemic corticosteroids for infants that are not intubated is unclear, and probably they are harmful. Longer-term follow-up in late childhood is vital to know to help us to choose the right regimen to use. So, inhaled steroids, early inhaled increased mortality are not recommended, and late inhaled we have a lack of data, so they are not recommended. Inhaled versus systemic, so inhaled cannot be recommended over systemic with the data we have today. Regarding intratracheal combined with surfactant, it looks very promising. So we need to wait for the results that are going on, but results are very promising. They are not yet recommended, but I don't know if they will be in the future. So I'm going to conclude my talk. The role of corticosteroids in preventing or treating BPD is not clearly established until today. So corticosteroids have been studied for more than 30 years, but we don't know everything. We know many things, but we don't know everything. So we need more studies to assess the best regimen to use. We don't have it by now. Early prophylactic low-dose hydro and corticosteroids with surfactant mixtures seem promising for the future. Balancing risks and benefits, that's what I'm talking about today. Systemic corticosteroids after the first week of life may be used in infants at high risk for bronchopulmonary dysplasia, which in clinical practice is to extubate the ventilator dependent infants because they have the highest risk of bronchopulmonary dysplasia. Whichever drug you use it, DEXA or hydro, its dose and duration should be minimized. So my take-home message and my conclusion is that we can use low-dose systemic steroid after the first week of life to extubate ventilator-preterm infants. Okay, so this is the recommendation of most of the authorities today, according to the data that we have today. And thank you for your attention.